You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for November 22nd, 2024. This week, an AHA review including Option, Summit, VANISH 2, SARA, and CLEAR trials. First, though, This Week in Cardiology will take next week off for the Thanksgiving holiday. Second, I wanted to say thank you to the Swiss EP Society for the invitation to speak here at the Swiss Rhythm meeting in Lucerne. This was my first visit to Switzerland, and I am shocked at the beauty of this country and how perfectly everything seems to work in Switzerland. There was one special experience I want to tell you about. I spent a day with the EP group at the University Hospital Basel. We did a research conference and then we ate lunch in the hospital cafeteria. There were about 10 people. Lunch also included espresso after the food. I commented that it was nice to eat with the whole group, but they said mostly they eat every day as a group, which is remarkable because it was such a big and busy EP group. Yet they said they make it a priority to stop and eat and talk together during the day. And I don't know how your practice is, but we rarely make the time to sit and eat and have espresso together. But the culture of collegiality and friendship should not be underrated, and it was so impressive here. All right, first topic is the Option trial. I have written 2 columns already on this trial of post-ablation stroke prevention strategies. New England Journal of Medicine has published a study. Option compared to strategy to implant the left atrial appendage closure device at the time of left atrial ablation and AFib ablation, and then stop the anticoagulant versus the continue the DOAC anticoagulation after the ablation. The results were presented at AHA, and they were nearly exactly as I predicted in my pretrial column. The trial enrolled 1,600 patients after AF ablation and randomly assigned them to continue with oral anticoagulation, that was a control arm, or to have a left atrial closure device inserted and discontinue anticoagulation after 90 days. The idea, of course, was to show that left atrial appendage closure could decrease the rate of bleeding while maintaining a low risk for stroke after ablation. Patients were 70 years old on average, 35% were female, and the mean CHA2DS2-VASc score was 3.5. Just over 40% of patients had appendage closure at the same time as their ablation, and the rest had had the device implanted weeks later. The results. The primary safety endpoint was non-procedural major bleeding or clinically relevant non-major bleeding, and it occurred in 8.5% of patients in the device arm versus 18.1% in the anticoagulation group. That hazard ratio was quite low at 0.44, and the confidence intervals were highly significant, and it was positive for superiority. 2/3 of the bleeding events, however, were non-major bleeds, including things like bruising, epistaxis, lacerations, and even oral bleeding. The primary efficacy endpoint of stroke, systemic embolism, and death occurred in 5.3% of patients in the device arm and 5.8% of patients in the anticoagulation arm. And that was close enough to meet non-inferiority, and I'll discuss why in the comments. The secondary safety endpoint, which is the more proper endpoint, that included major bleeding, which includes procedure-related bleeding, occurred in 3.9% of patients in the device arm versus 5.0% of patients in the anticoagulation arm. That hazard ratio was 0.77, and the confidence intervals went from 0.48 to 1.24. This met non-inferiority, but not superiority. Death rates were similar in both arms, 3.8 versus 4.5. Ischemic stroke rates were super low and also similar in both arms, 1.2% versus 1.3%. And remember, in a non-inferiority trial, you aim to establish non-inferiority of an efficacy endpoint, but superiority in safety. The top-line results of OPTION confirm this for left atrial appendage closure versus anticoagulation, but a closer look at the endpoints and trial procedures, I think, refutes this contention. Now, as I wrote in the column, which I've linked to, is that there were 4 major problems with OPTION. The first was a wrong primary safety endpoint. Safety cannot be established as superior with a non-procedural bleeding endpoint because the main safety concern with left atrial appendage closure is procedure-related bleeding. To assess safety properly, they should have used the secondary endpoint of major bleeding, which included the procedure. Here, the rates were 3.9% versus 5.0%, and that did not establish superiority for the device. The choice to exclude procedural bleeding from the primary safety endpoint wasn't my only issue with that endpoint. The inclusion of non-major clinically relevant bleeding creates a possible bias because this is an unblinded trial. Patients on anticoagulation may be more likely to report non-major bleeding events. Things like bruising and oral bleeding were actually higher in the oral anticoagulation arm. And you could actually see this bias in the Kaplan-Meier curves for the primary safety endpoint because they diverge immediately in favor of the device, despite the fact that the left atrial appendage closure patients were initially taking an anticoagulant and aspirin. So these immediate diversion is unexpected because more intense antithrombotic regimens should cause more, not less bleeding than anticoagulation alone. Now, the second problem was the wrong efficacy endpoint. The reason to do left atrial appendage closure or anticoagulation after ablation is to prevent thrombotic events, not death. Including death with stroke and systemic embolism in the composite endpoint simply inflates the numbers of primary efficacy endpoints, and as I predicted, the rates of death were quite similar. Yet, even with these inflated rates, the actual event rates of 5.3 and 5.8% were far lower than what they expected at 10% versus 15%. Now, this is important because the fixed non-inferiority margin of 5% is based on the expected event rates, and it translates to a relative risk of 1.5. In other words, left atrial appendage closure could have been 50% worse in terms of efficacy and still have met the threshold for non-inferiority. When the actual event rates come in much lower than expected at 5.3 and 5.8%, the absolute risk difference of minus 0.5% has an upper bound of 1.8%, which is well below the non-inferiority margin of 5%. But again, that's calculated on the basis of an expected event rate of 10%. Now, proponents might say, John, even with the lower event rates, non-inferiority was still met using the relative risk ratio. This is true. The hazard ratio of 0.91 had a confidence interval that went from 0.59 to 1.39, and the upper bound of 1.39 is indeed less than the margin of 1.5. But I would argue that this is deeply misleading because the actual stroke and systemic embolism rates were 1.2% and 1.3% respectively. And that means it would have taken nearly 5 times more patients to properly establish non-inferiority in efficacy. OPTION, therefore, cannot tell us whether left atrial appendage closure is non-inferior to anticoagulation for reduction of stroke and systemic embolism. It is basically 100% uninformative as a comparison trial for efficacy. Now, one thing we did learn, though, is that stroke rates were very low 3 years after ablation, and this suggests that we should have an arm of no device and no anticoagulation. The low stroke rate counters the view of many appendage closure proponents who argue that the device could be an alternative option for patients who do not want to take anticoagulation. I would argue that based on this finding, a better alternative in low stroke risk patients could be no device and no anticoagulation. This comparison has never been tested in the trial, and this OPTION result certainly argues for such a trial. The third issue with OPTION was missing data. The missing data for 144 patients, or 8.8% overall, with most of these patients in the anticoagulation arm, 10.5% versus 7.4% missing in the left atrial appendage occlusion arm. This is a lot of missing data, and the reason why I say that is it's higher than the actual safety endpoints, the correct safety endpoint, and the inflated efficacy endpoint. And missing data like this much just adds more uncertainty to an already uninformative trial. The fourth issue I have with option is that there's a possibility of harm because of incomplete left atrial appendage closure. The authors report that a complete seal of the opening to the appendage with a device was observed in 80% of patients at 12 months. So the translation is that 1 in 5 patients had a leak, and device-related thrombus occurred in 2% of patients. The two issues here are that the option trial was done at expert centers. In the United States, large numbers of AF ablation and appendage closure will be done by low-volume operators. And so the incomplete seal numbers in option probably represent a best-case scenario. If the results of this trial lead to a large increase in the implantation of these devices, there is a risk for serious harm on a population level. The second issue with incomplete seals is the short duration of the trial. An implanted device that doesn't completely seal the opening to the appendage may be forever. Anticoagulation drugs can be stopped. A device in the heart cannot be easily removed. So my friends, overall, option should not lead to more appendage closure. The data is just not convincing, despite what it says in New England Journal of Medicine and the positive top-line results. I worry so much that we could create an immense harm for putting this permanent foreign body into people. Here in Switzerland, my colleagues told me that option will have literally no effect on their already very low implant rates. But in the U.S., I have already seen social media posts from key opinion leaders describing concomitant left atrial appendage closure at the time of ablation. And based on the popularity and numbers of AF ablation, the downside risk from this strategy could be really significant. All right, next topic is the SUMMIT trial, Tirzepatide. At AHA, Dr. Milton Packer presented the SUMMIT trial, which randomized about 700 patients with heart failure and preserved ejection fraction and obesity to Tirzepatide or placebo. This is an important question to ask because A, HFpEF is now the most common cause of heart failure, and B, obesity is a common associated condition in HFpEF. In fact, obesity may also be more than associated with HFpEF. It may actually be causing HFpEF. And we also know that this class of drugs induces weight loss, and Tirzepatide is the most potent GLP-1 in the category. As background for the HFpEF question, 2 small semaglutide trials, the STEP-HFpEF trials, have showed that semaglutide induces weight loss and improves quality of life in patients with HFpEF and obesity and type 2 diabetes. These trials enrolled small numbers of patients who had very low numbers of heart failure events, so the conclusions regarding clinical outcomes could not be made. The SUMMIT trial aimed to assess the typical heart failure endpoints of CV death and heart failure events, though they expanded the heart failure event endpoint to include 3 things: the typical heart failure hospitalization, or IV therapy in an urgent care setting, or intensification of oral diuretic therapy. And before I say anything about the patients and results, note this subtle change of heart failure hospitalization and its endpoint. I mean, an increase in oral diuretics is a really soft endpoint because a patient could say they feel full or had a little edema, and the doc changes furosemide from 20 to 40, and that hardly seems like a serious event. Now, they also had a change in KCCQ as a co-primary endpoint. Patients were 65 years old, slightly more than half female, 53% recruited from Latin America, 22% from the US, 15% from Asia, and then from other places. Nearly 3/4 of patients had class 2 heart failure. The average BMI was really high at 38, high sensitivity CRP also high at 5.8. The results were highly positive. The primary endpoint occurred in 9.9% of patients in the Tirzepatide group versus 15.3% in the placebo arm. That's a hazard ratio of 0.62 with confidence intervals from 0.41 to 0.95, and obviously that meets statistical significance. The benefit, however, was driven only by a reduction in heart failure events, 8% in Tirzepatide, 14.2% in the placebo group, and most events were raising the oral dose of diuretics. Now, just to give you an idea of the small numbers of events, there were only 12 versus 26 admissions for heart failure. CV death was actually numerically higher in the Tirzepatide arm, 2.2 versus 1.4%, but this was only 8 versus 5 cardiovascular deaths. So we don't want to make too much of that, but again, CV deaths, we could at least say was not different at all. The average percent body weight decrease was substantial, 14% versus 2%. Of course, the KCCQ was positive. I won't discuss it because we expect it to be positive due to the weight loss. And of course, there's blinding of a patient in such a trial is near impossible because patients are going to know they're on the drug. And as far as my comments go, the unblinding issue I think is quite important, though it is no fault of the authors. These drugs cause GI symptoms, decreased appetite, less ability to eat big meals, and even some nausea, so surely most patients guess their treatment arm. And unblinding of patients can also affect heart failure events, right? Because patients in the placebo arm who aren't losing weight may be more apt to complain of symptoms requiring medical attention. And I'm sorry about this criticism, it's not personal, but I cannot see SUMMIT as an informative trial. There is no reduction of CV death. The heart failure event, like adjusting oral diuretics, is quite soft, and there are small numbers of events. Interesting that I recall Dr. Packer highly critical of the CASTLE-AF trial of AF ablation in heart failure patients versus antiarrhythmic drugs. Why was he critical? Because it had so few primary outcome events. And I think it's exactly the same thing here. Now, that said, if you have a patient who has HFpEF and a BMI of 38, weight loss is obviously a good thing. When you lose weight, it's likely that you have fewer events of any sort. You feel better. The authors invoke a reduction in inflammation as the mechanism of improvement, and they argued for a GLP-1, GIP type mechanism independent of weight loss. And I would push back on that, and if that were true, you have to show me something more than a reduction in heart failure events and oral diuretic adjustments. Show me a CV death reduction. Now, the other thing we don't know is the proportion of heart failure hospitalizations versus total hospitalizations. People with HFpEF have lots of competing risks of hospitalizations. I don't know why this data wasn't reported. Surely they have the data. It was an important thing to come up with because remember that in the HFpEF trials for the SGLT2 inhibitors, the number of heart failure hospitalizations was a very small proportion of total hospitalizations. The GLP-1A drugs clearly represent an advance, but this trial should not compel us to prescribe them as a heart failure drug. Many of these patients have diabetes or established atherosclerotic vascular disease or CKD, and for these indications, yes, but for HFpEF, we're going to need stronger data than SUMMIT. All right, next topic is VT ablation, VANISH 2. The question is how best to handle a patient who has had previous MI, ischemic cardiomyopathy, and an implanted defibrillator, and now presents with VT. The three choices are antiarrhythmic drugs, or ablation, or actually just it's a one-off event and let it go. Usually, though, if the patients get a shock and they have scar and it's sustained monomorphic VT, we don't usually choose no therapy because we assume there's going to be more VT. Drugs have the advantage of being easy. You simply take a pill. When it works, the VT is suppressed, you follow the patient, and everything seems fine. But drugs are not always effective and can cause adverse effects. The ablation procedure has the advantage, potentially, of being curative, but of course it is invasive and it comes with procedural risks. Dr. John Sapp led the VANISH 2 trial, which randomized these two choices. The trial was conducted in 22 centers in Canada, the US, and France. Patients were about 68 years old. The mean EF was depressed at 34%. The trial enrolled just over 400 patients. The primary endpoint was a composite, but I think a reasonable composite. Trialists chose death from any cause, VT storm, appropriate ICD shock, or sustained VT that was below the rate cutoff of the ICD. I like this composite endpoint because all of them are hard endpoints that are resistant to bias. either alive or dead, that has no bias, or you have VT or you don't, there's no bias. Unlike, say, heart failure hospitalizations, there were no clinical decisions required for these endpoints. Now, VANISH 2 is obviously open label or unblinded, so it's important to have bias-free endpoints in an unblinded trial. The results. The median follow-up was good at 4.3 years. The primary endpoint event occurred at 51% in the catheter ablation group versus 60.6% in the drug therapy group. That hazard ratio was 0.75 in the 95% confidence intervals, went from 0.58 to 0.97, and the p-value was 0.03. The four components of the primary endpoint were as follows. Death were similar, 22 versus 25%. VT storm similar, 22 versus 23%. Appropriate ICD shocks were numerically lower in the ablation arm, 30 versus 38%, but this did not meet statistical significance. But again, I would remind everybody that the trial's not powered for individual endpoints. And the fourth endpoint was VT below the rate cutoff, and this was much lower in the ablation arm, 4% versus 16%. Remember, though, that these are actually small numbers of events, but the delta was bigger. Adverse events within 30 days after the procedure included death in 2 patients and non-fatal adverse events in 11.3%. Adverse events in the antiarrhythmic drug arm included death from pulmonary toxicity in 1 patient and non-fatal adverse events in 22%. I saw one important subgroup finding. That is, most of the beneficial effect of ablation occurred in patients who were sotalol eligible. So sotalol eligibility required numerous factors, all of which indicated a healthier patient. Go into the supplement. Figure S2 showed the Kaplan-Meier curves of sotalol eligible versus amio eligible patients. In amio eligible patients, the Kaplan-Meier curves for the primary endpoint were nearly the same, no difference. All of the difference is in the sotalol eligible patients. VT ablation did much better. So my comments. This is a well-conducted study. It addresses an important question, and the endpoints are low in bias. Catheter ablation of VT did reduce the risk of the composite endpoint over antiarrhythmic drugs. The absolute risk reduction is 10%, a number needed to treat of 10. That is a clinically relevant effect size. But I see 3 caveats. First, most of the benefit appeared in sotalol eligible patients. These were healthier patients who had good kidney function, little congestive heart failure, and less severe VT on presentation. The reason for this heterogeneous treatment effect could be because healthier patients do better with ablation, or it could be due to amiodarone being a more effective antiarrhythmic drug. In fact, this heterogeneous treatment effect is similar to what we've seen in the VANISH 1 trial, which studied VT ablation versus escalation of antiarrhythmic drug therapy. In other words, a patient on sotalol or amiodarone would have VT, and the question was, do you just give more antiarrhythmic drugs or do you do ablation? And VANISH 1 favored VT ablation, but there was also an amio-sotalol heterogeneous treatment effect. In VANISH 1, if you were on amiodarone and had VT, then ablation was better than just taking more amiodarone. But if you were on sotalol and had VT, VT ablation was no different from switching sotalol to amiodarone. Since both trials have nearly the same heterogeneous treatment effect for amylo taken together, it strongly suggests to me that amiodarone is quite equivalent to VT ablation. Now, the second caveat is the main driver of VANISH 2 came in non-fatal outcomes. Lower rates of VT under the rate cutoff of the ICD is a common thing with antiarrhythmic drugs because the drugs, especially amiodarone, have the effect of slowing the rate of VT. Showing up with a VT at a rate of 130 beats per minute is not ideal, but is almost never fatal. I think the most important caveat, though, in VANISH 2 was that this trial was done in 22 very expert centers. VT ablation is challenging. It requires experience, patience. Low-volume operators who spend most of their time ablating AF may not have the same skills as those in the VANISH 2 trial. We call this an external validity question. The authors did nothing wrong. External validity just needs to be considered by those of us who use the evidence. External validity being, how do we translate this evidence to patients in our clinic? Unlike the option trial, I doubt that the VANISH trial will lead to an overuse of VT ablation. Yes, it was a positive trial, but VT ablation is hard, it's time-consuming, it's sometimes harrowing because the patients are sick, and compensation for the time is low, considering how long the procedure can take. Yet, VANISH 2 results allows us to sit down with patients and discuss the results. How best to apply these results turns on clinical judgment and, of course, patients' values. Before this trial, there was little data to inform this decision. I say congratulations to Dr. Sapp and the VANISH 2 team. Next topic is Cardioprotection, the SARA trial. The SARA trial tested sacubitril valsartan against placebo for protection of the heart during chemotherapy with anthracyclines. Now, anyone who's practiced cardiology for a while knows how bad anthracyclines can be on LV function. Of course, much of this toxicity is dose-dependent. SARA was a small trial, just 114 patients, average age 52, 90% women, and the trial was done in the beautiful city of Curitiba, Brazil. We just visited there for the EP Society meeting in Brazil. Patients enrolled had to have an elevated high-sensitivity troponin, and most were receiving anthracycline for breast cancer. Now, the issue with this trial, and the reason I highlight it, was the endpoint of greater than 15% reduction in global longitudinal strain of the left ventricle. I am not an echocardiographer, but GLS is surely a surrogate endpoint for cardiotoxicity. The results were quite positive. The primary endpoint was 77% lower with the ARNI compared with placebo, 7.1% versus 25%, and that p-value came in at 0.015. And this was independent of cumulative doses of anthracycline or HER2 positivity, the presence of hypertension, and age. On average, the GLS improved by 2.5% in the treatment group and worsened by 6.5% in the placebo group over the course of the study, and this too was positive. To me, the more impressive finding was that the ARNI group were less likely to have an ejection fraction of less than 50% as measured on CMR. This was 3.7 versus 17.0%. Now, obviously, this trial was small and clinical events were rare and occurred at similar rates in both groups. It wasn't powered for clinical events. My comments. I'm an outside observer looking in here. I found a 2024 review article in JACC CV Imaging that covered strain imaging. It went on for tens of thousands of words, and even though I'm a cardiologist, it was way over my head. The thing is, I see this as just a start. It's nice that a new echo parameter like global longitudinal strain is better, but I'm not sure that any patient ever has cared what their GLS is. They want to not have left ventricular failure or cardiac events. And the makers of sacubitril valsartan have plenty of money, and I hope that they will fund a proper study powered for clinical endpoints. And I've said many times, the proper comparator for a sacubitril valsartan trial is valsartan at the same dose. Had this been done in Paradigm HF, there would be no controversy over ARNI drugs in HFrEF. Now, I don't mean to be negative about an RCT. We need RCTs, but this trial had a large attention on social media, perhaps because it was a late breaker. I think it is the first of 9 innings in the cardioprotection game, but I could be wrong, so if I'm wrong, reach out and teach me something. All right, next topic is the CLEAR trial. Spironolactone and colchicine. Spironolactone is an amazing drug for patients with HFrEF. It probably helps those with HFpEF too. The Canadian CLEAR trial studied it in post-MI patients. Recall that the CLEAR trial was a 2x2 factorial design that also tested colchicine. The colchicine arm was presented at TCT, and it was stone cold negative, and I've covered it before. At AHA, we heard the spironolactone portion of CLEAR. New England Journal published 2 separate papers, one on the non-significant colchicine results, as well as the spironolactone arm. To review, CLEAR randomized patients after MI and PCI to either spironolactone or placebo and either colchicine or placebo. The 2 co-primary endpoints were a composite of CV death or worsening heart failure, and then a second composite of MI, stroke, new or worsening heart failure, or CV death. The trial enrolled more than 7,000 patients from 104 centers in 14 countries. Follow-up was 3 years, and again, spironolactone, non-significant. For the first primary composite outcome, it was 1.7 per 100 patient years in the spironolactone group versus 2.1 per 100 patient years in the placebo group. That hazard ratio was 0.91 in confidence intervals that spanned 0.69 to 1.21. The p-value was like 0.51. And it was the same with the second endpoint, 7.9% in the spironolactone group versus 8.3% in the placebo group. And again, no difference, hazard ratio 0.96. CV death was similar in the two groups, 3.2 versus 3.3%. So my comment, the non-significant results of CLEAR, I think, show that drugs are neither bad drugs nor good drugs. Spironolactone, for instance, is amazing in HFpEF. The ROUSE trial is one of the most impressive trials in all of cardiology. But after MI and PCI, even with a STEMI, the same drug does not improve outcomes. This makes sense, right? To get an effect size, you have to have both treatment-related benefit greater than harm, but also you need a high risk of the primary outcome. If the primary outcome risk is low, it's hard to make it much lower. And that is the case, I think, with AMI and PCI. After you fix and open an artery, you restore blood flow, you save myocardium, not much else changes outcomes, that is, except antiplatelet drugs and lipid-lowering drugs. Spironolactone fails post-MI for the same reason that beta blockers have been failing. The risk of the primary outcome is so low, it's hard to make it much lower. The CLEAR investigators also published the Colchicine part of the trial, and I've covered this before. This too was not significant for the same reasons. The curious thing about the Colchicine story is that why the CLEAR trial in post-MI patients was different than the positive Colcott study in post-MI patients and the low-DOCO study in patients with chronic coronary disease. I don't have an answer for that, but the CLEAR trial had a lot of patients and a lot of events. It is a very strong trial. So that's it for this week in cardiology. I went a little longer this week because of the coverage of AHA and because next week is the Thanksgiving holiday. I will be back in 2 weeks. And remember, if you like this podcast, please take the time to give us a rating, write us a review. If you don't agree with something I said, write a comment, send me a note. I always like to learn things from these comments. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.